There is evidence in the literature that ranolazine is useful in patients with diabetes. We have the TERESA study in more than 1,100 patients. We showed marked reduction in the angina frequency in these patients and in the consumption of GTN. There are data from Chapman and colleagues of the anti-anginal efficacy of ranolazine in patients with diabetes, reducing the anginal episodes and the GTN consumption dramatically. Again, in this study by Chapman and colleagues a few years ago, you can see how ranolazine reduced levels of HbA1c in patients with chronic angina and diabetes. Both CARISA and MERLIN, using ranolazine 750 milligrams twice daily and 1 gram daily, was associated with a reduction in HbA1c levels in patients with diabetes. Ranolazine was very important in this study in lowering HbA1c in patients who have not only diabetes but established coronary artery disease, and there was no evidence for hypoglycemic episodes. This slide shows the data in the MERLIN study where ranolazine decreased HbA1c compared to placebo. That was quite a significant change. Very importantly, the association of diabetes and coronary artery disease was very well tackled by ranolazine, which reduced not only HbA1c, but also recurrent myocardial ischemia in these patients with diabetes in this very large study. The findings in MERLIN stimulated the design of another big study, which is RIVER PCI. This was a multi-center randomized double-blind placebo-controlled study in different countries around the world with over 2,600 patients. And although ranolazine did not reduce the composite rate of ischemia-driven revascularization or hospitalization, and I think there is a very good reason for this, patients with diabetes improved dramatically their symptoms. And I believe that this is also telling us that we need to identify the mechanism for ischemia in our patients, not assume that everything is triggered by an obstructive coronary problem. So ranolazine in patients with diabetes was extremely effective, confirming data from previous studies. And there is a more recent study testing ranolazine in patients with diabetes, which I have summarized here for you for just a couple of reasons. First one, because it's a very well designed study. Secondly, because it showed that confirmed study the findings of the previous studies that I mentioned to you, where ranolazine reduces HbA1c in a large proportion of patients, and also because it investigated the mechanism whereby ranolazine exerts its effects on the glucose metabolism. It looks as if ranolazine inhibits glucagon secretion from the pancreatic alpha cells by inhibiting their electrical activity by a blockade of the sodium channel. And this has been confirmed in animal models of diabetes. We know that high glucagon increases the rates of glycogenolysis and gluconeogenesis, increasing the production of glucose by the liver. So a drug that can actually affect these mechanisms, like ranolazine, will have an anti-diabetic effect. So the concomitant reduction of both glucagon and glucose by ranolazine in this trial indicates that ranolazine affects glucagon secretion from the alpha cells. And this is a very important finding of this study. And these are the references that you may want to look at in relation to those effects. So the results of the ECHO study shows that ranolazine could be a very good option for the management of angina in patients with coronary artery disease and type 2 diabetes. So we have seen in this relatively brief presentation that patients with diabetes and coronary artery disease benefit significantly from the use of ranolazine. But my talk also highlighted the fact that patients with chronic coronary syndromes, particularly those who cannot tolerate conventional medications, benefit from ranolazine. Patients with angina after successful revascularization, particularly those with diabetes, improve dramatically with ranolazine. Patients with microvascular angina have been also shown to improve symptoms with the use of ranolazine, particularly those with reduced flow reserve. Elderly patients with chronic ischemia and multiple risk factors with low blood pressure, slow heart rates benefit from the use of ranolazine. And ranolazine can be used in patients in whom other anti-anginal effects with hemodynamic mechanisms cannot be used. There was no significant QTc prolongation with ranolazine in the studies I have shown to you, but of course there may be QTc prolongation in different conditions, which I have listed here for you, and you will most likely avoid the use of ranolazine under these circumstances. There are clear contraindications for the use of this medication, which I have listed here, and these include severe renal impairment, moderate to severe hepatic dysfunction, and the co-administration of class 1A or 3 antiarrhythmics, except amiodarone, and potent CYP3A4 inhibitors. The dose titration that I described today goes from 375 to 750, 1 gram in America, but the maximum dose in Europe is 750 milligrams twice daily. In conclusion, and based on what I have actually shown to you today, I believe that ranolazine contributes significantly to the armamentarium available for treatment of chronic coronary syndromes. Its lack of hemodynamic effect makes it suitable for use in different clinical scenarios. In recent years, many randomized placebo-controlled trials have confirmed its benefits in patients with angina pectoris, improving functional capacity and decreasing anginal episodes. The effect of ranolazine on the sodium current is promising at different levels, and evidence exists that ranolazine can decrease the incidence of ventricular tachycardia and possibly of atrial fibrillation. And ranolazine has an acceptable safety profile and a clear role in the treatment of chronic coronary syndromes as recommended by the recent European guidelines for the management of angina pectoris. Thank you very much.